Today's guest is Dr. Kalli, an airway-focused dentist, educator, and founder of Toothpillow, a company dedicated to supporting healthy oral development, nasal breathing, and airway health in children through early intervention and functional support. Dr. Kalli is passionate about helping families better understand the connection between oral function, sleep, breathing, jaw development, and whole body health. Her work focuses on identifying root causes early, from mouth breathing and tongue ties to poor sleep quality and developmental concerns, with the goal of supporting healthier growth patterns before more invasive interventions may be needed later on. In today's conversation on the Holistically Well podcast, we are diving into some of the most commonly asked questions from parents with young children surrounding tongue ties, oral appliances, airway development, bedwetting, pelvic floor health, tonsils, and adenoids, and how to know when intervention may actually be appropriate. Dr. Kalli, welcome to the Holistically Well podcast.
Thank you so much for having me, Kayla. This is going to be a great time. I am eager to spread the word and help moms identify how they can help their babies live and breathe better.
Love it. Well, let's start broad. Why airway health
Okay.
matters in the first place. So many parents hear the term airway dentistry and assume this is simply about straight teeth. Can you explain what airway focused dentistry actually is and why it matters for whole body health?
Well, gosh, I would love to. I mean, airway dentistry does result in beautiful straight teeth, but I like to say it is actually the side effect of what we are doing in our treatment, which is just beautiful. Every organ in your body needs oxygen. We know that we cannot even live very long without oxygen. And I don't think people really understand the gravity of making sure that our sweet babies are breathing well at night while they're sleeping because of the issues you can have with IQ and learning and attention and all the things that we're going to get to digging in today about why this treatment is so important. But traditional dentistry or traditional orthodontics and airway dentistry, honestly, right now couldn't be more divided, which is really sad. And the way that orthodontics was done on me as a child, and maybe you, I don't know your orthodontic story, it was just not done well. It was not done with expansion and breathing in mind. Antiquated techniques like extraction of teeth to make room have got to go. They have got to stop. And it takes platforms like yours to really help spread the message for moms to understand that one, they can get a second opinion or a third or a fourth, however many they need, and that this decision that they make early in their child's health, in my opinion, will be the one with the most gravity going into how a child ages and will turn into an adult and ultimately their longevity. It's very, very important.
Wow. So, what are some of the earliest signs you notice that a child may not be breathing or developing optimally?
Yeah, probably the most obvious in like your little babies as they're growing is just mouth breathing. Like if they're playing with a toy or they're sitting, watching a movie with you or whatever, if you look and observe them and they're just like a constant like mouth open posture, that's not normal. And so those are the kinds of things I try to just like let's see how simple we can make it. Identify, these top 3 or 4 signs that if you notice in your 1-year-old, 2-year-old, 3-year-old, that should be cluing you into what is going on with their nasomaxillary complex. Like, how is their overall development of their nasal passages, how they intake air, all of that? How is that developing right now? Because a child's head and neck development is 55% complete by age 2. I don't think people realize that. Like by age 2, and that's still too young even for a tooth pillow. So it's like, what do we do even leading up to that age to try to support our babies as well as we can, which comes to nutrition, making sure they don't have tongue and lip ties, things like that. So the mouth breathing is probably the number one sign I would say. You got to make sure your children can breathe through their nose. It is so important. It literally changes the shape of their face. Like it literally, they will look different if they are a mouth breather than what they were, genetically supposed to look like. So that's really important. The other, as they get, a little bit older, maybe age 4, 5, 6, would be tooth grinding. Tooth grinding is one of the most common things we see in general dentistry, which is why I preach when I'm teaching to doctors. Grinding is not normal. It is never normal. There is an underlying root cause when their bruxism, which is the fancy word for grinding, is happening. And we need to make sure we don't tell parents that it's normal and they'll grow out of it, which is what I was taught in at dental school. I went to a very good, very well highest housed dental school. And that was still what was being taught even as I graduated. So it's really important important that we start changing that narrative because mouth breathing, tooth grinding, snoring, even upwards of bedwetting and behavior issues are just glaring signs that our poor babies are struggling to breathe at night and we need to do something about it.
Absolutely. We will be diving into some of those topics specifically as we move through today's interview. But first, why? Like, what in our environment is causing children to be mouth breathers versus the biological design of nasal breathing?
Goodness. I mean, some of my mentors and people that have studied anthropological data over hundreds of years have said that we are so many generations in now that it's almost like every child has this problem. So while I don't believe that it's an entirely genetic issue at all, it is heavily associated with the change in Western culture and diet if you look back just a few hundred years ago. So as we introduced more processed foods, as breastfeeding became less popular, especially in the 70s, 80s, 90s, it's just one of those things that as we changed certain aspects of our child's nutrition and lifestyle, more melt in your mouth foods and applesauce pouches and things like that, our muscles are worked way less. There's also a big difference in bottle feeding and breastfeeding, which I did both with my kids. This is not an episode to like shame anybody who's bottle feeding. Like some moms have to do that for sure. But I think the narrative that they're equal is wrong and was misleading to moms because of the muscle component of breastfeeding. So the babies have to work a lot harder to get the milk out of a breast than they do a bottle. And I usually say if you dump a bottle upside down, watch what happens. The milk just kind of comes out. So their tongue can just do like little swallow movements with a bottle versus a really proper latch on a breast and how much suction and muscles that it takes to actually get the milk out when they're breastfeeding. So again, not a shame against people who are bottle feeding. It's just a difference in the way the muscles have to work. And so then when you transfer from that to everything is mashed, everything is soft, then these babies aren't chewing the most that they're supposed to. And our chewing function is so incredibly important. We work a lot with a company called MyoMunchie, which is encouraging people. I don't know if you're familiar with MyoMunchie, but encourages
Yeah.
babies really, really little to just be chewing and chewing and chewing. And that stimulates so much growth and development and so much tongue function that they're not necessarily getting from their diet as well. So we've created this issue with diet and then the genetics, the genetic line of being so many generations in of crowded, crooked teeth that now we have to have all these adjunct services available to the families in order for them to be able to try to get ahead of the problem. So yeah, it's a big deal.
Okay. And I love that you broke apart like genetic versus environmental because, for instance, I breastfeed my babies. They get bottles the 2 days of a week that I am in the office, but
Sure.
otherwise they are to breast. We do more of like a food first approach where it's not just mashed foods, but
Good.
that like baby led weaning approach to
Yay. Perfect.
give their jaws room to develop and all of that. But even in my own children, I've like watched and I'm like, are you mouth breathing? Like we
Hmm.
do all these things, you know? So I like
Yeah.
that you kind of also bring in the historical aspect of like genetically over time, like maybe our society is adapting to Western culture and some of this may just be ingrained from birth. Is that kind of what you're getting at
Yeah, it's
here?
it's a smaller component for sure. I think people want to use genetics as the full excuse, and some of them to the extent of like, oh, there's nothing we can do about it because
Okay.
they're like me, and I'm like, no, you can completely change that if we can get in early. So
Mhm.
yes and no to that particularly. Like, I don't want people to think that they can't do anything about it, that we're just stuck with this because there are so many things we can do. But right now, even if you look at countries that have way less processed foods, honestly, more third world style countries, the decay rate is so much lower, the jaws are so much wider. It's crazy. So I know that if we can get in early enough and change the way they're swallowing, chewing, the tongue tie thing is very genetic. Like if we can fix that stuff and catch it early, we can totally change the trajectory of how that child grows, which is the most beautiful part about it.
Amazing. So, talk for a moment about the Myo Munchie that you mentioned and using with little babies. What exactly is that?
Yeah. So this tool is meant for the babies to be chewing, 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 and swallowing. And so the more they're chewing on something, the more they're using your muscles. It's like working out, you know? And if we don't work out and we don't use those muscles, you say that you lose it, don't use it, you lose it or
Mhm.
whatever. So with little ones, and they're growing at an exponential rate right now. We're talking about like exponential growth happening. And if their mouths are just still and they're barely swallowing or everything, nothing requires a lot of force or chewing, they're not going to develop like they should. So the MyoMunchie is an incredible tool. We're actually in my practices using it on adults because we need
Okay.
to keep doing that too. So it's like it's crazy because the more you use your muscles, the stronger your bone density. We know with women and weightlifting and things like
Yeah.
that, like we've got to be doing that. It's not that much different when it comes to your tongue muscle and your jaws. So it can work for a beautiful amount of people. And I think anybody who's paying attention in the airway space should be having their kids in a MyoMunchie tool. We have a beautiful collaboration with MyoMunchie through our Toothpillow virtual platform. I also use them at the Airway Dentists, which is my brick and mortar locations around Houston, Austin, and Dallas. It's a great tool for our kids. And what I was saying earlier, you really don't start a tooth pillow until about age 3. So what are
Right.
we doing from the 0 to 3? That's a huge passion project, especially for the president of Tooth Pillow. And so we're working on creating like the best, box that we can for that age. And the MyoMunchie is just an essential tool and discussion of that with us.
Awesome. Thank you so much for sharing that because my children are 4 months old, 2 years old, 4 years old, and 6 years old.
Yay.
So
Oh, beautiful window, Kayla.
I know. So I'm like, this episode is just so spot on for me. And I'm probably going to go
Yes.
order a Mayo Munchie after this call.
Good. Good.
So,
Yeah.
another reason today's topic just really caught my attention is because I'm a pelvic floor physical therapist and I take a very holistic approach with my patients. We talk a lot about the nervous system, we talk a lot about breathing. So, with the topic of mouth breathing, nervous system, and pelvic floor health, can you explain the connection between these areas and even bedwetting and stress and pelvic floor function, how that all relates back to kind of mouth breathing and nervous system health?
I mean, I think the closest and best correlation for your audience to understand is just that if you have any sort of sleep disorder breathing or obstructive sleep apnea, you are in constant fight or flight at night. So if we're thinking nervous system regulation, you're not regulated when you don't breathe. I mean, you have your brain has one job at that point, and it's to make sure that oxygen gets delivered to the rest of your body, and your heart is pumping like crazy. So anytime we have this just induction of adrenaline to the system, which happens every time you stop breathing and you start again, it is like people don't understand. It's like 911, like, oh, we will breathe now, and it's like, it's a shock to the body. So nothing is going to work well when that happens. I mean, I've talked about this in regards to thyroid issues as women get older too. When it comes to pelvic floor and the breathing, let's talk about just even the pressure that they have identified on sleep studies that happens in the thoracic cavity, which is really bad on your heart. So if we're talking about bedwetting in children and the hormone changes that happen when the atria stretch in the heart, or even as an adult, when you're having to get up and having frequent urination at night, it's a whole hormonal imbalance. So how could we expect anything else to be working fully properly? Right? Like
Right.
it just doesn't make sense. And that's why I think with anybody dealing with issues that they're like, well, I shouldn't have to deal with this, or, I shouldn't have pelvic floor dysfunction, or my spine is not aligned well because your jaw is not aligned well. Like all of
Right.
it is so connected that I think we just need to be taking, like you do, a very holistic approach as to why is this happening in the first place?
Mhm.
Nobody wants a CPAP. Let's be for real. Nobody wants to strap that to their face for the
Right.
rest of your life. It is a very life saving device in very severe situations, but it's not curing you of the problem. And so, if we could, from an adult perspective, figure out how to get to a more stable cranium and jaw and all of that, it's going to support the rest of the body. And for little kids, could we prep them for adulthood so that they don't ever have to worry about this stuff?
Right.
That's my biggest passion is if we can get to these moms and make sure they understand how important it is to start treatment early, because our generation, I mean, we didn't put braces on until 13. It was all cosmetic. It's just, if you were wealthy, you got to have it, basically, if your parents could afford it. And it was a purely cosmetic mindset to the point of pulling teeth, making the airway space smaller for the sake of straight teeth. And so if we can just like change that narrative together and make sure parents understand how important it is to start early so that we could prevent some of these things. Oh my gosh, generations of kids and families will be healthier like every day.
Right. And obviously, the whole goal with this conversation is to educate you about the importance of preventative care and what proactive measures are available for you to take. But what about the mom listening, the person,
I
who is
know.
in our age range, who didn't have
Yeah.
access to this, who was like, oh my gosh, like I wake up 4 times a night to go pee. And I'm working with this person in terms of urge incontinence and, how we can calm the pelvic floor, calm the nervous system so that pelvic floor is in a more relaxed state. We're releasing any myofascial trigger points. We're doing all of the orthopedic and pelvic floor physical therapy work, but what airway dentistry side of things are available to this adult?
Yeah, lots of things actually. And I think it's important to highlight because people don't really think that there's much aside from a CPAP, right? If you have obstructive sleep apnea. Like I have patients who are like, no, I don't want a sleep study because I don't want a CPAP. And I'm like, well, good news is you don't maybe have to have that. Like, let's just, it's important to still screen, but there are a lot of different things. So in my brick and mortar practices, we treat all ages from 0 to 100. Teeth
Right.
and a pulse is what I need, is what I say. And we have options that are very non-invasive, like clear aligners, Invisalign. Okay. We have things that we can do to upright teeth and make more room for your tongue, which is just a beautiful experience for people. It is the easiest, I would say, of all of them if you qualify to have that as your main sleep treatment, which means are the teeth tipped in? Can we upright them? Can we make more room for the tongue? Or is the entire jaw system too small? In which case we do use non-surgical approaches in our practices. It is a really hot topic right now in airway dentistry. Let me tell you, the gloves and the fisticuffs and all the things about like what the right way is to do it. But you absolutely can do this non-surgically. We have done it. We have helped so many people. I have had people that were on CPAP get off of CPAP because we did non-surgical expansion. There are also great options like MARPI. MARPI and Dome are probably the two most popular in social media right now, where everybody's getting it implanted and screwed into the roof of their mouth. And I'm not against that at all. It's just about what is best for the patient and meeting them where they're at in their journey, and understanding the severity of their case too is really important. So there's as easy as Invisalign all the way up to surgery for your jaws to widen them. We also make traditional snore appliances. Like as old as dentistry gets into sleep medicine, they make appliances that gently hold the lower jaw forward. And if you can imagine, when you do that, it pulls the tongue out of the back of your throat, so you're not desaturating, you're not having these apneic events at night anymore. And those are gold. I mean, for people that don't want to change their smile, they like their smile, they just want to have something to protect them at night. Super, super important for pregnant women. I cannot stress this enough on this podcast. If you are pregnant and you have not been screened for obstructive sleep apnea, you must. Because there are very simple things that we can do for you while you're carrying that precious baby to make sure you and the baby stay healthy throughout the duration of the pregnancy and getting through delivery. So very, very important. So yeah, we have a lot of options for mamas that are listening.
Awesome. And so this brings to mind as well teeth grinding, because we see a huge connection between jaw tension and pelvic floor health. So we will see clients in the office with TMJ issues. Some were given night guards by their traditional dentist. What is the difference between a traditional night guard versus what you're describing that kind of helps pull the lower jaw forward? Is it even the same thing? What should they be asking for
They
if
couldn't
they
be
are teeth
farther
grinding?
apart from each other. Yeah, like I'm so glad you asked that. They could not be on farther spectrum. So we have a rule in our practices that we will not even make a traditional night guard for a patient unless they have had a sleep study, because we know that bruxism is basically obstructive sleep apnea at this point, and the literature would agree with that. So it's part of our screening process. So the difference is the night guards are typically made from the upper arch, and they do protect your teeth. I'm not here to say they don't protect your teeth. If you've got veneers and, a Cadillac in your mouth of dentistry, then yeah, I understand why it got made. But at the end of the day, I care a lot more about how your oxygen levels are at night than how your teeth technically look in the back if you've been grinding them. So, and I know that the grinding, we can protect you from that, and we can protect your investment and also help your airway at the same time. So the plain and simple of it is anything your dentist puts in your mouth will have the opportunity to make your airway bigger or smaller. Okay. At the end of the day. So if you put in an upper night guard, which I've made many of these in my career. Okay. I did all the things wrong too. I pulled teeth for braces. I did all the things. That anything you put in your mouth is going to take up tongue space. Tongue space is your best investment. Nothing can take up your tongue space. We need everything to be helping your tongue with space in your mouth. So if we put something that goes over your teeth, it is going to block some of your tongue, and it's going to prevent you from making that nice seal of your tongue up against the roof of your mouth. Really, really important. So if we're going to put anything in your mouth, it needs to bring your lower jaw forward at the same time, because if all we do is put it in and it kind of opens your bite up a little bit, your jaw is a hinge. If we open your bite, it's going to push that jaw back. That's really not what you want. You don't want your jaw back at all, ever, really, but definitely not while you're sleeping. So It will protect your teeth, but it's not going to do anything for your airway, and that bruxing is still happening. So that's another thing is it's not stopping you from grinding your teeth. It's just trying to lessen the damage that happens from the grinding, which is a really important delineation between the two. So I always recommend a mandibular advancement device, which is that fancy term for a better night guard because it
Wonderful.
includes both arches and it helps keep your airway open.
Wonderful. That's so helpful to know. Now, can a traditional dentist, like anybody's regular dentist, be able to get them one of those, or do they need to reach out to a airway dentist specifically?
You have to go to somebody that's been trained in it. Now, a general dentist is legally able to make one 100%, but you won't find that at every office, unfortunately. Because if they've never taken a class on it, there's no way they can make you one. And you want it to be made well by somebody who's trained in it. So I usually tell people reach out to me on social media. I get hundreds of messages a week on where I can go, who do I see in this state or that state. And I know people in all the states of the US that I can help try to navigate. Obviously, for younger kiddos with our virtual care model, but for adults that need a snore appliance, that would be in office. And I'm happy to help.
I'll be getting the Ohio names from you
Absolutely.
after
Okay,
this
great.
recording so that I
Good,
can
good.
refer patients that way because that is incredibly helpful to know. So, shifting from the mamas, our age group, to children, why do some children continue bedwetting well beyond what parents expect?
Just so rough. And unfortunately, they don't typically end up in a dental office when they have bedwetting. Nobody's associating your jaws or your teeth with that kind of an issue.
Right.
So there's a hormonal component and an oxygen component to why this will happen with kiddos. And we talked briefly earlier about the pressure on the atria of the heart, which
Mhm.
changes your hormone exchange and can make you make more fluid in your bladder. And if you're in a really deep state of sleep, it can cause you to void without waking up. So there's a few different foods for thought on this. One also includes the oxygen level change that your brain recognizes. And when it pulls oxygen from tissues that it needs in order to service the brain and the other tissues during these apneic events, it can cause kids to void if the oxygen's pulled from the bladder. So we have the hormonal component, then we have the oxygen component, which are all critical. The thing is just what do you do about it?
Right.
And I have seen kids that come in at 9, 10, 11. I had one that was still happening at age 20. That's wild. I mean, despite all medical interventions, nothing had ever gotten it taken
Goodness.
care of. And this patient had sleep apnea. Nobody had ever thought about that. Like, is this what we're thinking? But for kiddos, the biggest issue is making sure they've got to be able to breathe through their nose. So, yes, the jaw development, yes, the expansion, yes, the tooth pillow. I mean, the tooth pillow, as far as I know, is the only orthodontic appliance that has literature to support how quickly bedwetting stops once they put it in. So, it's a huge deal, huge deal. And so, that is the go to for us in practice, both with virtual care and in my brick and mortar locations. And then we have to decide, are we also going to do expanders? Because do we need to get in there and start making this wider, quicker, based on age, basically? If like they're 9, 10, 11, 12, like we're getting really close to that window closing, we got to get in there quickly and start
Sure.
widening things. But the interesting thing is we have found that kids who are bedwetting, 50% stop in 2 weeks, 80% stop in 8 weeks. It's really crazy with these tooth pillow appliances. And that's a bell curve, of course. So anytime I'm talking to parents about it, I'm like, they're going to fall somewhere in this. I've had some where we're 4 or 5 months in and it's still happening, but it's a lesser volume. We're making progress. And there's basically a trifecta of prescription that I give them. And I'm like, this is what you have to do to get the best result. One is you got to wear your tooth pillow, like period. Every night has to be in your mouth. Do whatever you have to do to make that happen. The second is nasal hygiene. We notice that if kids get congested and they were bedwetters and maybe it stopped and then they get a little cold or whatever, they could have an accident. And I go, that is the power of the nasal breathing. Like that is how drastic. And then obviously goes away again when they clean their nose or when they get over the cold. So that's very normal for any parents listening to this. Don't be like devastated because it came back and then you think like, oh, it's not working. It's just pay attention to their nasal patency, to pay attention to how well they can breathe through their nose because something probably changed that week and we can get back on track. So nasal
Right.
hygiene is a huge component. And then the third is myofunctional therapy. So myofunctional therapy is critical for muscle and tongue development, especially if there's a tethered tissue like a tongue tie or a lip tie. That's
Sure.
a huge part of our virtual model and my brick and mortar locations is we've got myofunctional therapists we work with all over.
Okay.
And so those are the three things: tooth pillow, nasal hygiene, potentially expanders, and myofunctional therapy. So those three things, if you want the best result as quickly as possible for your child, are what we need to be doing it.
Amazing. So this ties right into tongue and lip ties. This was one of the biggest questions submitted by listeners
Really? Okay, good.
was around tongue and lip tie releases, specifically when intervention is truly necessary versus when a more conservative approach may be appropriate. And I know you're typically intervening when children enter more the toddler stage and not newborn, but as we've discussed today, like there are so many options we can do early on. So, what are the risk versus benefits of release through your
Yeah. For me, we see kids at newborn age in brick and mortar location.
Okay, amazing.
We offer cold lasers to release
Okay.
tissues on babies so that they can breastfeed better. I've done that for years
Okay.
and it is so important. When we get but I think just to narrow it, like, do we really have to do it or can we wait? Let's just
Right.
talk about the
Yes.
importance of it. So, if your child has a frenum that is preventing them from getting a good latch, not only is breastfeeding going to be harder, it's going to be shorter because they're going to take in more air. They're going to take in, and your supply feedback will be different. So I've had moms where they start losing their supply because the baby's not fully emptying them. And if you don't fully empty, then you're not going to replenish that and more. And so it really can affect a woman's ability to breastfeed for longer periods. And that's just a big deal in my book. Like that alone, I'm like, despite what anybody says, like if your child has a bad lip or tongue tie and as a newborn, it's like so good to get it taken care of while they're little because then it's just done. And your tongue's job is a palate expander. Like it's your God-given built-in palate expander. And so if that tongue is sitting low, and I've got my own story on this because I had mine fixed when I was like 37 and mine was
Okay.
horrible, tip to end, like my whole life. Never had an issue eating, never had an issue talking. Like, and the pediatrician, especially back in the 80s, was like, nah, she's fine. And I mean, we're talking, mine was like, if you saw the pictures, you'd be like, whoa. And I usually joke that it's incredible I amounted to anything in this life with a tongue tie like that, because it was just like really bad. And I suffered all sorts of ways in my life, like chronic neck and shoulder tension. My neck would go out so badly practicing dentistry once or twice a year, bad enough to cancel a day of patients. And
Wow.
that didn't happen ever again since I got my release done. And so
Interesting.
this isn't like, oh, it used to happen. It was like consistently would happen multiple times a year, my entire career. And then it never happened again when I got my tongue tie fixed. So like, it's incredible. So I'm a big, big advocate for it at a younger age.
Okay.
When it comes to, let's say ages 3 to 5 or 6, where parents are having conversations around like sedation, that like increases a level of risk with having it done, of course, just because maybe they can't tolerate it. They're really young, like they need to have it done. Hopefully they can just do it with laughing gas or something like that. But like if we're having to weigh the pros and cons of like IV sedation versus having it done between the 3 and 5 age, there's going to be a lot of opinions on this. I'll tell you, the comment section will be unleashed, but I think you have to weigh the consequences of not doing it during that growth period. So if a child is struggling with speech, you need to get it done. If your child has sleep apnea, like it's an important thing to have done because any amount that you can increase their oxygen levels at night is literally going to change their brain health and their IQ. Like we know this is in the literature. So it's really important. So I'm a big fan, as you can probably tell, of getting it done. But I can understand like if it wasn't that bad of a tongue tie
Right.
on a 3 or 4 year old and the myofunctional therapist says that, not just the dentist, like they have identified that they could stretch it and make some improvements without having a surgery that requires some sort of sedation, wait. And then do it when they're 6 or 7, when they can tolerate it, if you don't want to put them to sleep. But if it's something that's really going to restrict their palate growth, like let's get it done. We just need to get it done. It's a quick procedure. If you're going to somebody who knows what they're doing, this will be
Mhm.
something they do every day as their bread and butter. And it's like, just get it done and it's going to help your baby a lot.
Okay. So, do you recommend myofunctional therapy before release typically?
It's a requirement.
Okay.
Yeah. I went,
Huh.
except a newborn. Like
Okay.
our 3 year old. It's like really hard to do some things at that age, right? Like we will
Sure.
release a newborn. We work with craniosacral chiropractors and lactation consultants. So we make sure that somebody's on board to help with the stretching and the healing after, because that's not our avenue. But when it comes to the ages where they can sit down and do their exercises and do their myofunctional therapy, we require it in order to do a release. It
Amazing.
will grow back. It will grow back worse. You'll have scar tissue. You'll waste your time, your money, and it costs a lot of money to get all this stuff done. So myofunctional therapy is a must.
Okay. I love that you mentioned that because obviously, as a therapist myself, as a conservative minded provider, it's like if we don't change the mobility of the muscles and the fascia, then exactly as you said, it's just going to regrow right back. Right. So, like thinking of
Yes.
a root cause approach, we need both to
Yeah,
get it done. Now,
absolutely.
whenever it's a more mild tongue or lip tie, do you ever see those resolve with myofunctional therapy alone?
Yes, great question. So I was just going to get into that because I think some, not really airway dentists, but some dentists will say, oh, this tongue tie fad, right? Oh, every frenum y'all see you think needs to be cut. And it's like, that could be farther from the truth. And actually, I tell my patients, I see a frenum here. Most of us have one. Whether or not it's restricting you is not my expertise. That's up to the myofunctional therapist. So there's some that are very obvious, like it's attached in between the two lower front teeth.
Sure.
Everybody's going to say you should get that off. And I've seen that. I've treated that before. It's wild. But on the ones where I'm kind of on the fence, stretching it and getting past the, like, you don't have a scar, like you're not going to have a wound that has to heal all day, every day. So I just make sure I work with really great myos that will tell the parent the truth. And it's not just like we're cutting all of them to cut them. We want to make sure function is good. And so if it's inhibiting function, despite all of their best efforts, then we will be doing revisions.
Okay. Amazing. Thank you for clarifying that. And what
Yes.
what would be the symptoms or functional limitations that a parent should be watching for to consider a release?
Well, there's a lot of things. If you pay attention to like the way a child chews and swallows, that's a big clue. If they're smacking a lot, one of the things that we do is we have them go as wide as they can. Just open your mouth, and your tongue should lift up and touch the roof of your mouth. So we measure like how much does the jaw have to close when you do that. And it was so funny. Like literally, my max opening was 6 millimeters before my release. Like to have my tongue up where it needed to be, I couldn't even separate my teeth. Like it was crazy. And so to be able to go all the way up is a huge deal. And so those are kind of the things that we look for, but you really don't want to guess on this. Like you don't want to try to evaluate it yourself and then not go see a myo. Like I can't stress enough, just do a consultation with a myofunctional therapist that's been in practice for a while so that they can really do a proper analysis, because some kids will not be tied at all. And you'll think, oh, we don't need any of that. And that is false. Actually, most of my tongue thrusters, which means they push their tongue through their teeth when they swallow instead of up and back, are not tied. Again, this is anecdotal. This is just my experience. I see anterior open bite, they bite down and the front teeth don't touch and that tongue just goes through. I don't see a restriction, but we have major muscle dysfunction. And that is part of the myofunctional therapist's job to retrain.
Okay, incredibly helpful. Another parent asked, I have a 3-year-old, but I'm afraid she won't tolerate a device or guard yet. Should we start with therapy first?
It's a great question. So, yes, you can always get a consult from a myofunctional therapist. I think it would be wise to use one that is familiar with these types of appliances like MyoBrace, the Vivos appliances, MyoMunchie, because if you go to somebody who's never used any of that stuff, I worry you won't get the best advice. As far as being concerned that your 3-year-old won't wear it, this is what I have this conversation all the time. And my best message to the person that sent you that message is you have to let them try. 3-year-olds have been some of our easiest patients that we've ever treated. They want to please. And I started my youngest at 3. It took him probably 4 to 6 months to keep it in his mouth all night. We made it fun. It's not serious. I don't like, we have so much time to get this all fixed. But if he starts now, the changes are going to be measurable. He's 7 now. He's got beautiful jaws. Like, had I waited till he was 7, we'd be a completely different world right now. So I'm not opposed to bribery with these kiddos, whatever Lego they want or whatever toy. I say, put it up on top of the fridge, let them see it, but they can't have it till they wear their tooth pillow. Trust me, they're going to want to wear their tooth pillow.
Yeah.
So I think as moms, we have a lot going on. You know, the dishes are in the sink and the dryer needs to be emptied. And we're thinking one more thing that we're going to have to put on our babies to like make them do.
Right.
But it is absolutely worth it. And you have to let them try. Don't assume they can't,
Okay.
because they absolutely can.
And can you explain to parents listening, what is a tooth pillow for those who don't know?
Yeah, so it's not a proprietary appliance. A lot of people think I invented something. I wish I did. I would just go down in history if this appliance was mine, but they've been around a very long time. Like none of this is new, which is also really important. But my company decided to bring it to the masses because I was like, I'm going to have to reach more people than I can reach in my private practice. And I want to make Toothpillow, which is what I called the mouth guards. There are a lot of brands that we use for the patients. And I just called it that because I don't like the word mouth guard for obvious reasons. And I would always tell patients, like, this is a pillow for your teeth. It's going to help your teeth and help you sleep better. And it was just something I used in private practice forever. And so we decided to name the company that. And I wanted it to become a household name, which I believe it is coming to that now. A lot of people are hearing about it. And it is it's like a myofunctional appliance. They are prefabricated to various widths, and depending on what teeth you have how many teeth you have is what size you'll be given. And the size grows with the child as they get older. But it does 2 main things. This is really important that I want people to understand. Growth appliances that we use are doing 2 things. It's redirecting breathing through the nose So it'll help when they put it in. It kind of looks like a big football mouth guard. They put it in and it's going to force nasal breathing, not in a harsh way. Like they can spit it out if they're really congested. We say don't wear it if you're sick, things like that. But it's going to induce nasal breathing and it's going to redirect musculature. Okay. So when they have it in, we have various colors, but blue was like the most common for a long time. So they smile, you just see blue everywhere. The blue is actually, there's a gap between the tooth and the lips. So when they put the tooth pillow in, the lips are now off the teeth. And it does not take much pressure from lips or tongue to move teeth. People don't realize that. Your lips and your tongue literally determine the position of your teeth in your mouth. So we get the muscles off the teeth. We bring that lower jaw forward a little bit because the little tooth pillow appliances will help bring their little jaws forward. So if they have an underdeveloped jaw, it's going to literally stimulate it to grow forward while they're developing, while they're growing, without mechanics, without surgery, all of the great things. And so when it redirects that musculature, that's what allows all the teeth to line up. And it looks like we've done braces on these kids. If you look at our before and afters, they're absolutely stunning. And people are like, what did you do? And I was like, never put a bracket on the kid. Not one time. All they did was wear their tooth pillow. So induces nasal breathing and redirects musculature. And the side effects are all the pretty straight teeth that we get from it.
Amazing. And this is a device that the child would just wear at night when they sleep, correct?
Yeah. So for the little ones, we tell them to just put it in when they go to bed. As they get a little bit older, and then there's some of the larger appliances, we tell them we want 1 to 2 hours of daytime wear and all night. So beats the heck out of having something glued in 24/7. I can tell you that. But wear it 1 to 2 hours a day. So for a lot of our families, I say when they're doing homework, I see thousands of homeschool families and they're like, we got plenty of time. We can get our wear time at any time,
Yeah.
But for the kids that are going to school during the day, I'm like, don't bring it to school, but just, wear it when you get home, especially before bed, if you're doing homework or whatever, to get some of that active musculature and swallowing happening prior to going to sleep.
Love it. Now, what is the ideal age window for intervention?
My gosh, nobody's off limits. Okay. So I don't want this to limit anybody. For our virtual care model, we only accept submissions between ages 3 and 12 right now. Now we are coming out with a teens and adults in the future. But right now, for those appliances that you see us posting about, you can submit between the ages of 3 and 12. The most ideal I would say is between like 3 and 9. Because by the time we see them at 9, 10, 11, 12, most of them are getting referred in office for full-on expanders. So the earlier, the better, truly.
Awesome. Very, very helpful. So I have heard that from those who, may have a different line of thinking than you at Toothpillow, that those devices just tilt the teeth outward. They don't actually create jaw and mandibular growth. What would you say to that?
I would just say I think they've never done one in their whole life because those little phalanges on the appliance don't even touch the teeth. So there's like literally no way for that to happen. I have heard people say that they think that the front teeth get pushed in. Literally, we're correcting negative bites with it. So that would be impossible if that was happening. If you see underbite pictures of ours, they literally come forward and overlap. So there's I would just say, I doubt the people that are saying it have ever used this. They certainly haven't done as many as I have. I don't think anybody has in the world right now, honestly. And so it's just misinformation, plain and simple. Yeah.
Okay. Well, I appreciate you speaking to that
Of course.
and addressing these questions directly on. So let's jump into tonsils and adenoids. What are some signs that enlarged tonsils or adenoids may be contributing to airway dysfunction in children?
Chronic sinusitis and chronic mouth breathing. Like I've seen some of the worst tonsils that you've ever seen. And there is definitely a line on we can expand and help shrink them for sure. In the literature, we know we can do this. And this child is going to continue to suffer and they need to come out. That is probably the second most common DM I get on social media is, do I have to get my child's tonsils and adenoids removed? And it's always like, well, it depends on how bad they are. Because if they are stopping breathing, snoring, some of the videos people send me, Kayla, like on social media would just make you want to cry. Because it's so bad. And these moms, I had a patient once, I kid you not, this was probably 5 years ago. This mom comes in and she is just disheveled, okay? And she had an appointment and was running late, no big deal, whatever. But she comes in and it's just like a fire, I could just tell. And she was ready for battle. We'd never met each other before, but she was like, somebody is going to help me with my kid. I will never forget this. And so he sits down, he's the cutest little thing. He's probably like maybe 4. And she had more videos on her phone that she had taken to physicians, ENTs, you name it. And it was videos of him stopping breathing at night. Like they're just awful. And then she's wanting to know, is there anything I can do? Because the ENT wouldn't take the tonsils out because he didn't have strep throat enough. And I'm like, we need a new ENT right now. Like, because the ones I work with would never allow this to happen. But the saddest part about it is that she and her husband were taking turns staying awake at night, holding his little jaw forward.
Oh my
Like
God.
they would take shifts because he couldn't breathe otherwise. So it is when it's really bad, obviously that is like an extreme scenario. They have to be removed because nothing we're gonna do is gonna be fast enough to improve the
Right.
oxygen levels. And there's just like we have to, yes. But on so tonsils are graded like, 1 to 4 or 0, like removed or whatever. And 4 is like overlapping, kissing, touching, they've got to go. Like no, and I've seen those. But pretty much anything below that, I want to try to shrink because there are side effects to that surgery. It is very expensive too. And anytime we can avoid sedation and surgery on a child, we should be doing that, period. End of discussion. And so the literature shows that rapid maxillary expansion shrinks the volume of the tonsils and adenoids statistically significantly. I think it was like 85% or something. And so we've seen that too with just tooth pillow appliances, which are going to bring the little jaw forward, which is going to open their airway and help them breathe through their nose so they can get that filtration happening again, which is the nose's job to help shrink the tonsils and adenoids naturally. But on some of them, we have to go in immediately with expanders with the tooth pillow. It's both. It's not either or. It's like they're going to wear their tooth pillow at night because that's the only thing that's going to bring their jaw forward and open their airway. And then we're going to be working on that transverse and AP expansion with expanders at the same time. So really, it depends on the age of the child. My 3-year-old that I was talking about when we started his airway journey, they were huge. They were huge. And my now 9-year-old did have hers out when she was like 2, I think, or whatever, before I was the dentist that I am today.
Yeah.
And it was no fun having that done, but I just thought that's what I had to do at that point. So when it came time for our youngest, I was like, oh my gosh, he's going to be in the same boat. Like, he's going to have surgery. No. And that is why I put him in an appliance so early. And he was so cute and little. And he's like, what do I do with this? And we're all just, it's like, it took some time, but his tonsils and adenoids are completely normal, completely normal. So I'm like, why wouldn't we be trying this on every single enlargement within a safe window to prevent these surgeries from happening? So I'm fired up about it.
Well, I love that you can speak to that as both a parent and a practitioner
Yeah,
because I think for those listening, it's just like, okay, I can relate. Like maybe you did have them removed for an older child, but knowing it doesn't automatically mean that that's going to be the case for your younger children and
absolutely.
that there are options out there. And it really does depend on the severity of
It does.
the symptoms. So, one thing that fascinates me about your model is that many families initially connect with you virtually. How are your practitioners able to assess a child remotely versus the traditional wait and see approach many parents hear from local providers?
It's just the most beautiful model. I'm like so proud of the teams and how we've built this. So, when we're assessing in office to kind of show you kind of talk about the differences, we were using and are using a pediatric sleep questionnaire, so the verified PSQ. That alone, I'm like, I could look at that and be like, yes, you need a tooth. Like if you're mouth breathing, snoring, grinding, bedwetting, any of the things, that's all on there. So we're going to take a full assessment remotely. And then we ask for a series of photos because I got to see you. I got to see what your teeth look like. I got to see what your tongue looks like. I got to see what your jaws looks like, your profile, your smile. Like we do a full intake, and I can tell that I'm an expert in this space, having done it as long as I can. I'm like, just show me one picture, and I could probably tell you that your mouth, like your jaw development is impaired. And these appliances cannot hurt anybody. They can do zero harm. So the risk is like literally zero, and it can only help. And so as we were building the company, we said, what do we need? What do we really need on a 3-year-old? Do we need a cone beam CT? Do we actually need a cone beam CT on a 3-year-old? Or do we need that when we get a little bit older if we're going to assess for expanders? So what do you think my answer was? Probably when they get a little bit older when they assess for expanders. Unless we need to see their airway. I need to see their adenoids, their tonsils. I need to measure their jaw angles. For whatever reason, it's rarer on a 3-year-old. I'm telling you, very rare. And honestly, in our practice, we don't take them that young unless the parent for some reason wants it. Like that's just, I knew was not needed. So obviously, as they get older, the diagnostics that we offer at the airway dentist with full-on cone beams and stuff is really essential because it does tell you a lot. But in the younger ages, we knew we didn't need that. So I've got parents telling me the medications the child are on, the surgeries they've had, the quotes that they've gotten, all of the things, and they just desperately need help for their child. Now I have your sleep questionnaire and all your orthodontic photos. We're ready to go. So that intake gets screened by the state level treating provider. They look at the case. They decide, is this appropriate for virtual care or does this child need to come in office? And we always get sad when it's like go in office situation because some of the families are 3 or 4 hours away.
Yeah.
I mean, like, we do worry that by declining the case and saying, like, I'm so sorry, like they're 11 and they have blocked out canines and they need all this orthodontic work, that maybe they'll just never get it done.
Sure.
Like, are they going to go? It's very expensive. So, but we can't offer a treatment that is not going to be appropriate to age. So the
Mhm.
denials that we have to do are upwards of 50% between like 9 and 12 years old. So
Sure.
that's why when you said ideal age, I'm like, younger the better. I don't want anybody to
Right.
be told no. And I do think it's important for the public to know that, because obviously doing what I do now at the level that I do for Tooth Pillow, the scrutiny and the rumors and the commentary and all the things live on the internet. And it's important for people to know that this is not a DIY direct to consumer sort of like click here, buy, everybody's getting it.
Yeah.
That's not how it works. And I really want people to understand that. Like, it is vetted and verified by a dentist who decides yes or no to the treatment.
Mhm.
And then the parents have the option of going forward with it or not, obviously.
And then how do you determine the size that the child is placed in without measuring specifically within office?
So we do measure, actually. We have proprietary measuring cards for tooth size once they get older. So when they're all baby teeth, that size is universal. Like, it's made to fit on what they call primary teeth only. When they get their first permanent molars and their jaw has grown more in this direction, they have to be upgraded to another size. That is another one that has no indentations in it. It's like a big well that's going to hold the jaw forward. Everybody starts in that one. It does the most muscle and tongue positioning of any of the appliances, the two starter ones. So everybody starts in either the baby one or the one that is appropriate when you have your permanent first molars. You have to graduate out of that one in order to go into our what they call tooth positioner appliances, which is where things start lighting up like braces. It's gorgeous. But you have to start with the muscle part of the whole thing, as we've discussed, because it's critical. And at that point, we have measuring cards that the families, we have a really cool AI is awesome now. I mean, I
Awesome.
know exactly how big your teeth are.
Yeah,
So
that's
I have everything I need
fantastic.
behind the scenes. Yeah, in order to pick that third appliance, because if you've started like really, really little all the way up, you would have about 3 appliances. So that one, we know all the widths and measurements, and we just send it to you that way.
Okay. Well, that is super helpful. Now, if a parent listening today remembers one thing from this conversation about their child's airway health and development, what would you want that takeaway to be?
I would say don't ever put braces on your child without making sure that their arches are big enough for the rest of their life. Your decision and who does tooth straightening on your child will be the biggest decision I think we make as moms right now. And you need to make sure you have an absolute expert doing that. Otherwise, you will go through braces many times in your life, as I have, and you could be given misleading and false information.
Well, we covered a wide breadth of topics today. Dr. Kalli, thank you so much for joining us. I feel like I
It's
could
my
just talk your
pleasure.
ear off for another hour, so maybe
I
we'll have to do a
know.
part two.
I would love to do a part two. I mean, I looked up and we're like 45 minutes in. I'm like, oh my gosh, there's
I
more.
know.
But yes, yeah, we
Yes,
could.
yes,
Yes.
absolutely. So we very well may hit record again someday, but this
Wonderful.
conversation was incredibly insightful. I know so many parents listening are going to walk away feeling both more informed and empowered to trust their instincts when it comes to their child's health and development. I especially appreciate the way you approach this conversation through a root cause lens, helping family with things like mouth breathing, sleep struggles, posture, behavior, and even pelvic floor concerns such as bedwetting that may all be more connected than we once realized. If a listener wants to continue learning from you, explore whether airway focused health may benefit their child, and work with your team directly, where's the best place for them to find you?
Yes. So I have 3 Instagram handles I want people to
Yeah,
have access to. One is my professional one, which is the Airway Centered Dentist, all spelled out. Then my brick and mortar locations around Texas are the dot airway dentists. And then our virtual platform all over the United States is called Toothpillow_official.
amazing. Well, thank you so much for sharing that. And thank you for all of your work in this space. I know that you are a
Thank
mom,
you.
and it is clear how passionate you are about this as well. And so, as a fellow mother who has a private practice and is very passionate about what I do too, I just feel like this is needed. And some moms are given this gift of being really passionate about their line of work too, and being able to help other
Mm.
mothers and families. So thank you for doing the work that you do.
Well, thank you also, Kayla. It was great to finally connect face to face like this. And I hope this podcast episode goes viral and everybody gets the information. And I look forward to future collaborations with you.
Awesome. We hope so too. If today's episode resonated, please, please leave a review about what spoke to you the most. That will help direct future conversations on the Holistically Well podcast. Until next time, take care and be well.
Bye.